आ जाओ आ जाओ। नहीं अभी स्टार्ट नहीं किया। आ जाओ। बस बस। तू अंदर है, फ्रेश वगैरह कुछ हो रहा है? और रेस्ट करना है तो मेरा सामान थोड़ा बिखरा रखा है ना, अब तो साइड में कर ले। कौन सा कर दो? हाँ हाँ, तुम जो जाए वो यूज करो। हाँ। First of all, happy Women's Day to everyone. First of all, happy Women's Day to everyone. First of all, happy Women's Day to everyone. Today, we celebrate the strength and achievements of women across the world. Women have been breaking barriers and making remarkable contributions in every field. Let's continue to support and uplift each other. Now, moving to the our session, it's my pleasure to introduce Dr. J.P. Shah, sir. He is MD, physiatrist and clinical investigator. Good evening, everyone. First of all, good evening, everyone. Happy Women's Day to everyone. Good evening, all. Happy Women's Day to everyone. Today, we celebrate the strength and achievements of women across the world. Women have been breaking barriers and making remarkable contributions in every field. So let's continue to support and uplift each other. And one of the example we have is Dr. Chandan Preet Kaur ma'am. She is MD PMR, professor in Department of PMR, Interventional Pain Management. Good evening, ma'am. Good evening, sir.
Good evening.
Hello. Can you hear me, ma'am?
Good evening, Dr. Ajay.
Hello.
Good evening, sir.
Good evening. Good morning over here.
Yeah, good morning to you,
Very
sir.
good morning, sir. Happy Women's Day, ma'am. Happy Women's Day, sir.
Thank you. Happy Women's Day to you too, Nagma.
Thank you, ma'am.
So we can wait for 5 more minutes, right? It's
Yes, ma'am.
5
Yeah.
minutes to 8, right?
Yes, ma'am.
Should I try to see if I can show my slides?
Yes,
sure that
ma'am.
works.
Yes, sir. Sure, sir.
Okay. And I just have to share screen. One moment. PowerPoint. There we go. Okay. Can you see the slides?
Yes, sir, we can.
Wonderful. Dr. Kaur, are you the moderator?
Yes, sir, for today.
Oh, nice to meet you. Where are you located?
I am in Punjab, sir, right now.
Oh,
So
okay.
I did my MD PMR from SMS Medical College, Jaipur. So in Punjab, in India, if you have visited, we have Baba Farid University of Health Sciences. So I'm a
Right,
professor
yes.
right now in PMR here.
Oh, okay, very good. Yes, yes. I typically go to the south. That's where my wife is from.
Oh, wow.
Bangalore. Yeah.
Nice.
Vellore. Yeah. How many physiatrists are a part of this academy?
Almost 250, sir.
Oh, wonderful.
Yes.
Okay. And
And
do you
we,
two? Uh-huh.
yeah.
Go ahead.
So we are relatively new. We just launched last year only.
Oh, very
Yes.
good. Yes. I don't know if Dr. Nitesh told you, but I met him. I think we were in the lounge at the after the ISPRM meeting in
Oh,
Sydney.
in Sydney. Oh, wow. Nice.
I'm pretty sure that's where I met him. And we just exchanged information, and then he emailed me a few weeks ago. Um, do you typically organize these on a Saturday night?
Yes,
This is
they do on a Saturday evening most of the time.
Oh my goodness. Okay. So you guys are hardcore. I like it.
Yes, and usually earlier we used to do like thrice a month. Like we used to
Uh-huh.
have one journal club,
Okay.
one webinars, and one case presentation series. So
Oh, okay.
yes, and
Okay.
once a year, twice a year, we started conducting live workshops as well, hands-on.
Wonder
Yes,
Wonderful.
so
Yeah, yeah, yeah. I do a lot of teach a lot of
awesome,
workshops, and yeah,
awesome.
so we can certainly communicate and talk more about that after you hear. So what I wasn't clear
So
about.
webinars we started every month,
Mhm.
right?
Yeah. So I believe I have 45 minutes, but possibly a little bit extra. Is that correct?
Pardon, sir?
I said I believe I have 45 minutes of lecture time and
You can take
possibly a
one
little.
hour.
I
Yes,
can take 1 hour. Great, great. That's perfect. Yeah.
yes.
Okay.
So it's a very interesting topic. So
Yes.
I think many people will like to listen to it.
Yeah. Yeah. It's
And
it's it's for us. It's really become our focus. So for many years we've been studying myofascial pain and central sensitization, and I'm going to sort of put the picture together and try to make it very um, thought provoking. And I hope it generates a lot of discussion and questions. And yeah.
hoping so. So you're based in Maryland, Bethesda?
I'm based at NIH. Yeah, I work at the clinical center in the rehabilitation medicine department.
Right.
Yeah, yeah, I've been here now. July will be 32 years.
Wow.
Yeah, but if you've heard of all the disruption and turmoil, we don't know what's going to
Right.
happen.
It's funny.
Have you been this side?
Sir, I do visit, yes. I come twice a year to US.
Mm-hmm.
So I have family there, like.
Where's your family?
So they're in Washington, in New York, in Miami,
Oh, in Washington
Toronto.
D.C.
Yes, my real sister.
Oh, so that we're just miles from D.C. Yeah.
Yes, it's not,
Yes.
everything is on the East Coast, so I know.
Oh, wonderful, wonderful. Yeah. And this group, is it mostly physiatrists exclusively, or are there other professions as well?
So in the academy right now, the membership is most of the physiatrists are there. But when we
Okay,
have a webinar like this, we do open to all the pain interventions and who are
wonderful.
non-members also.
Oh,
So
wonderful. Okay.
yes. So for once, it is open to all. So anybody who wants to learn, log in once they can.
Hmm.
And later on, for a long time, it is available to the members only.
Oh, I see. Okay. And do you have like CEUs or continuing medical education? Is that what's also provided as part of it?
Yes, sir. Totally.
And that's
Totally.
great. Yeah. Yeah. And I'm hoping there are also trainees, right? Residents and others as
Yes,
well.
sir. So
That's
trainees,
great.
it's a mixed
Yeah,
group.
yeah. Because the residents are the ones who are learning, and we teach residents and students and all the time. So
So consultants also learning. I think doctors are learning all throughout the
yeah,
life.
yeah, yes, of course, of course. But what my point, what I want to make is that it's really important for residents to learn this
Yes.
information in their training so they can
Right.
learn how to integrate it into their practice later. Yeah.
So shall we start the session, sir?
I
Sure. I'm
think
ready whenever you are.
we can. I think it's time.
Okay. So good evening, everyone. First of all, happy Women's Day to everyone. Today we celebrate the strength and achievements of women across the world. And women have been breaking barriers and making remarkable contributions in every field. So let's continue to support and uplift each other. And one of the example with us is here, Dr. Chandan Preet Kaur ma'am. She is MD PMR professor in Department of PMR Interventional Pain Management, GCS Medical College and Hospital, Faridkot. She is expertise in diagnostic musculoskeletal ultrasound and interventional pain management for more than 10 years. Ma'am will be moderating the discussion. And now moving on to our session, it's my pleasure to introduce Dr. JP Shah sir. He is the MD physiatrist and clinical investigator in Rehabilitation Medicine Department at the National Institute of Health, Bethesda, Maryland, USA. His interests include the pathophysiology of myofascial pain syndrome and the integration of physical medicine techniques with promising complementary approaches in the management of neuromusculoskeletal pain and dysfunction. He also completed the 1 year UCLA medical acupuncture course and a 2 year Bravewell fellowship at the Arizona Center of Integrative Medicine. Dr. Jay is a well-known lecturer on mechanism of chronic pain syndromes, including myofascial pain syndrome, dry needling, neuroanatomical acupuncture techniques, and other related topics. He and his co-workers, investigators, have utilized novel microanalytical and ultrasound imaging techniques that have uncovered the unique biomechanical, mu, and viscoelastic properties of myofascial trigger points and surrounding soft tissue. Dr. Jay has done novel collaborative research studies with gynecologists, neurologists on chronic pelvic pain and endometriosis. He and his team have published several landmark papers in this area. Moreover, their work has been internationally recognized as transformative by the World Endometriosis Foundation. Dr. Jay has hundreds of invited lectures and hands-on workshop courses nationally and internationally for physicians, physiotherapists, acupuncturists, dentists, chiropractors, and massage therapists. His presentation integrates the fascinating knowledge emerging from the basic clinical pain sciences in order to optimize evaluation and management approaches to chronic neuromusculoskeletal pain and dysfunction. He was also selected by the American Academy of Pain Management as the 2010 recipient of Janet Travel Clinical Pain Management Award for Excellence in Clinical Care, and also by National Association of Myofascial Trigger Point Therapists as the 2012 recipient of David G. Simons Award for the Excellence in Clinical Research. So, over to you, ma'am, for the moderating the session. We can start the session now.
Yes, without wasting much time, thank you, Nagma, for
Thank
introducing her so well. And without wasting much time, over to Dr. JP Shah for the session, please.
Yeah, wonderful. Thank you so much to the organization for inviting me and for this unique opportunity. I hope to meet you in person, and I do hope we have a very varied audience of practitioners, of students, anyone who's interested in myofascial pain. As you will see from my presentation, it truly runs the gamut. So I will be talking about the dynamic roles of central sensitization, which we call CSENS, and neurogenic inflammation in this syndrome. And I wish to show you how we can integrate pain mechanisms and objective findings, physical findings, and how this can guide assessment and treatment. So, as you know, no lecture on myofascial pain can be given without mentioning the seminal work of Janet Travell and David Simons, who emphasize the importance of learning the functional anatomy and the importance of palpation of the soft tissue, particularly taut bands where you can often find these myofascial trigger points. And when you press on a trigger point that reproduces the patient's pain, those are called active. So you've identified a myofascial component to their pain. Now, the trigger point manual is invaluable because it also shows you the functional anatomy. It shows you the most common referral patterns of trigger points. And I say most common with this caveat: once a person is sensitized, the receptive field of pain can widen out. So while it's a useful guide, it's not the exclusive pain referral pattern. Every individual can develop unique referrals, and we'll discuss that as well. Now, what's important to understand is the following, and that is that myofascial trigger points in any skeletal muscle, whether it's in the pelvic floor or extra pelvic area, what have you, this is a source of persistent nociceptive bombardment. And one of the consequences of that, in addition, is that you can have persistent bombardment also coming from endometriosis. Yes? So this information can then summate in the spinal cord, particularly at the level of the dorsal horn. And what it will do is phosphorylate the NMDA receptor, N-methyl D-aspartate receptor. And that has profound clinical implications, which we will discuss later. But what I want to draw everyone's attention to is something that is often overlooked, and it's a simple neuroanatomical consideration, and that is the following. 60% of our wide dynamic range neurons are located in lamina 5. Why is that important? This is a neuroanatomical finding, observation. It's because it's the wide dynamic range neuron receives input from skin, from bone, from viscera, from periosteum, and of course from muscle. And lamina 5 is one of the lamina that's preferentially activated by muscle nociceptive inputs, including from trigger points. So what I wish for you to think about is how this can explain the very common somatovisceral and viscerosomatic interactions and patterns that we often see. So for example, let's in recognition of International Women's Day, let's say that a patient has chronic pelvic pain, and the gynecologist finds the patient has endometriosis, and they treat the endometriosis with surgery, with hormones, etc., and they remove the lesion. The patient returns and says, "But doctor, I still have chronic pelvic pain." I cannot tell you the number of patients that I have seen in our clinical studies on endometriosis and chronic pelvic pain who've been told you shouldn't have pain. Not a good message, right? Now, think about what that is saying. That is saying, from the perspective of the clinician, that they are thinking of pain in terms of anatomy and structure. If the lesion is gone, the pain should be gone, right? They're not even considering central sensitization or the potential role of myofascial trigger points, whether they be in the pelvic floor or extra-abdominally, right? Rectus abdominis, urooblique muscles, etc. So one of the things that I'll show you is that these trigger points, as I said, are persistent sources of nociceptive bombardment, and this can have profound implications in terms of upregulation of these dorsal horn neurons. And what will this lead to? This can potentially lead to expansion of the receptive field of pain, allodynia, and of course, hyperalgesia. Now, what we understand and we integrate into our clinical practice is that once a patient is sensitized, you should see these clinical findings. So what you see here is I'm doing a simple clinical pinch and roll test on a patient with chronic pelvic pain. And of course, this is a test for allodynia. If the patient tells me that hurts, we mark those particular segments. We can also use a Wartenberg pinwheel to check for hyperalgesia, right? And that will, what you'll see the same patient, watch how she reacts right there. She's telling me right there, oh, that's more uncomfortable. It's a noxious stimulus, but where is it felt more painfully? So what are the zones that overlap in terms of the allodynia and hyperalgesia? Number one. And number two, you would see the same physical findings in the peripheral tissue, right? And dermatome, because it's all segmental. And this, as I said, has profound implications as it relates to the dorsal horn. But as I will show you, not only can the dorsal horn be sensitized, but so can the ventral horn, the intermediate horn, and even the opposite side. And this, again, has profound clinical implications, which we will discuss. So I wish to thank Dr. Nitesh Kanahi, who invited me, Dr. Kaur, thank you so much, and the Academy of Pain Physiatrists. It's truly my pleasure and my honor to be with all of you. I just want to tell you where I am. So I live in Bethesda, Maryland, which is just outside of Washington, D.C. And if you look a little closer, that's my office right there. And I live about 8 minutes away. I can walk to my office in about 8 minutes. But this is a unique hospital because we do what's described as bench to bedside and bedside to bench research. It's translational. So what are my colleagues in the laboratory learning that we can then translate to the bedside? And what do we, I'm assuming everyone here is a clinician, what do we observe clinically that we then have develop hypotheses and questions that we can then take to our colleagues in the laboratory? And that's what I hope to show you, what we've done in some of our studies. So I have nothing to disclose, except that, again, thank you for this opportunity. And I also wish to emphasize that I am part of a team, a magnificent team, an interdisciplinary team. My mentor, Dr. Lynn Gerber, is triple boarded: rheumatology, internal medicine, and physical medicine rehabilitation. Some of you may have heard of her. John Serbel is a former chiropractor who is also a neuroscientist, and he's the one who developed the neurogenic hypothesis. We have an outstanding physical therapist on our team, Cecily DeStefano, who's done dynamic work in the area of ultrasound imaging, looking at patients with hypermobility, chronic pain, etc. We have students with us, Yoni Asefa, Martin Mamura, who's a well-known physiatrist in Brazil, Siddhartha Sikdar, who some of you may have heard that name. He's the first author or senior author on many of our ultrasound-related publications. He's a bioengineer at George Mason University. And Antonio Stecco, who's done, and he and his family, his sister Carla, their family have done seminal work in understanding the role of fascia in myofascial pain syndrome. So we affectionately call ourselves the myofasciados, which is sort of a play on words of aficionado, but myofasciados. So what are trigger points? As you know, these are discrete, palpable, hyperirritable nodules. And the clinical construct that we have right now is active, meaning it's spontaneously painful, or latent, which means it's not spontaneously painful, but it shares all the same physical characteristics, including palpation of a taut band. Now, we appreciate that there's some confusion here as it relates to this question: are trigger points an all or none phenomenon? Because that's according to the Travell and Simons approach, active versus latent. And what I hope to show you is it's not all or none, that there are degrees of activity and degrees of latency. And this has to do with understanding the spectrum of sensitization. And this all or none phenomenon has created enormous historical confusion over the years, right? We all know about the different terms that have been used to try to describe this syndrome. But if we really want to understand what's happening in this neuromatrix of pain, as Ronald Melzack described it, we really have to look at the role that central sensitization and, as I will show you, neurogenic inflammation are playing in the syndrome of myofascial pain. So let's again put things in a little bit of historical perspective. The old, and I would say antiquated, view of trigger points was people would be dismissive of them and say, yeah, trigger points exist, but this is mostly associated with acute musculoskeletal pain. It's self-limiting, almost as if a child had skinned their knee. Eventually it will heal, and whether the trigger point goes away or not, the pain will certainly go away. This is called more of a peripheral problem. And of course, central sensitization, as we know, is associated with disuse, depression, disability. It's been called central sensitization syndrome. But what I'm going to show you is that truly what happens in the periphery, as I think most of you know, but I want to emphasize as it relates to trigger points, affects the central, and what happens centrally affects the peripheral nervous system as well. And all the things that we see associated with chronic pain in general, disuse, depression, disability, we also see with chronic myofascial pain syndrome, as our studies have demonstrated. So the more accurate way of understanding what's happening here is, again, based on our understanding of neuroscience, is that trigger points are a persistent source of nociceptive bombardment, and I will show you the evidence for that can sensitize the dorsal horn neuron, right? Now, we also know that there are changes in the limbic system in patients with myofascial pain syndrome. This includes the amygdala, insula, the anterior cingulate gyrus. We, as you all know, as pain physicians and aficionados, that there's dynamic modulation occurring between the brain and the spinal cord. such that in certain circumstances, the receptive field of pain can widen, right? Can increase, and as can allodynia and hyperalgesia. And our goal, of course, is to identify those pain mechanisms to reduce the receptive field of pain, reduce allodynia, hyperalgesia, eliminate pain. But again, understanding that there is this spectrum of sensitization. So what else do we know about this descending modulation? Well, we know as it relates to limbic system activation, we know that the limbic system, irrespective of how it's activated, it could be activated by persistent nociceptive input coming in from somatic structures, such as myofascial tissues, from the joint, from viscera. It could be happening because of psychological issues, right? Irrespective of how it happens, we see increased fear, anxiety, and stress, right? You can see increased heart rate, blood pressure, activation of the fight or flight system, right? So this dynamic modulation is something we have to be very mindful of, as well as the fact that we have so-called on and off cells in the rostral ventral medulla, which is part of the midbrain. And they do exactly what they sound like they do. What these cells will do, and what this essentially is a gate that can either facilitate incoming messages, okay, to create the perception of more pain, or ideally, with increased off-cell activity, inhibit it, right? So you can imagine now if you have circumstances where you have a relative increase in on-cell activity, what can happen? Supraspinal sensitization. So now we can start to appreciate the changes that occur supraspinally can now sensitize that spinal cord such that now even previously innocuous inputs coming in can sensitize, create more pain, more disability, etc., as we will discuss. So you can imagine now, let's say a patient develops pain over their deltoid muscle, right? And then that pain can spread, as we know the trigger points can spread. What happens if that then spreads over the pectoral area? The patient might perceive that they're having a heart attack, for example, but this could be entirely segmental, right? Because deltoid and pectoral muscles are innervated by C5, right? So we have to understand and explain what is happening as it relates to the limbic system. And two elegant fMRI studies have shown that patients with upper trapezius myofascial pain syndrome have increased limbic system activity, okay, and decrease activity in their contralateral dorsal hippocampus, which is that part of the brain that downregulates stress. Now, it's a chicken or the egg. Which comes first? We don't know. We're trying to investigate this. But this shows us right away that there's clearly a superhighway connection between these active trigger points and profound changes that occur in the central nervous system. And we're going to talk about how this has effects up and down the neuraxis. And this is very important as it relates to our understanding and assessment and treatment of pain. So it's truly exciting to appreciate that doors are opening all over the world as we're learning more and more about chronic pain, nociplastic pain, central sensitization, etc. And one of the things, thanks to the work of Dr. Siegfried Mensa, is that we understand that trigger points are not merely a peripheral phenomenon. As we said before, the input from trigger points leads to hyperexcitability of central neurons that manifests in allodynia, hyperalgesia, and pain referral. But number two, as I will show you, is so profoundly important for those of us who do physical medicine, because look at what this statement is saying. These central changes, again, in the dorsal horn are mainly based on increase in the efficacy of central connections that are being induced by nociceptive input. So what that tells us is that we have to identify these sources of bombardment, turn them off. But if we haven't done that, the patient's going to be sensitized. So in addition to turning off those sources, we also have to identify where the patient is sensitized and treat that, whether it's segmentally or supraspinally, right? So what is neurogenic inflammation? Well, the simple definition is that this is the antidromic release of neuropeptides, for example, substance P and CGRP. So let me put it to you in the bigger picture as it relates to what we know now about trigger points and why it's not peripheral versus central. It's what's happening in the periphery affects the central and vice versa. We know that active trigger points are associated with central sensitization, neurogenic inflammation, and limbic system dysfunction. So let me show you what happens. Let's say you have a patient who comes into your office complaining of pain, and you press on that area and you reproduce their pain. Well, our team has done microanalytical studies, and we have demonstrated elevated levels of inflammatory mediators, pro-inflammatory cytokines, these neuropeptides, a more acidic pH. Okay, any one of these biochemicals by itself, right, can activate and sensitize that nociceptive ending. What is the result of that? Again, increased activity towards the dorsal horn. But just before the dorsal horn is this structure, the dorsal root ganglion, right? That's what is releasing neuropeptides, substance P and CGRP. When those are released dromically or towards the dorsal horn, it's what we already discussed is going to happen. Increased activation of the NMDA receptor, opening it up, right? And now you're going to get some of those profound changes that can occur transcriptionally and then postsynaptically, right? And what I want to draw your attention to is this. The fact is that up to 70% of these biochemicals are actually being released antidromically, which means down the axon whence they came from. Now, what are the implications of that? Plasma extravasation, right? Recruitment of white blood cells, etc. So you basically can initiate the inflammatory cascade without injury occurring if you can trigger neurogenic inflammation. And how do we know neurogenic inflammation is occurring in myofascial pain? Because there are elevated levels of these neuropeptides and active trigger points. What are the clinical consequences of that? The following. You will certainly sensitize the dermatome. So, and excuse me, before the dermatome, the myotome, right? Because think about it now, that is being released along the C6, C8 segment, right? So any muscle sharing segmental innervation with C6, C8, such as your triceps, your wrist extensors, etc., can potentially become more tender, right? The myotome, as well as develop more tenderness in your trigger point, right? The dermatome, so the skin over that area, anything, and that would give you the allodynia, hyperalgesia. And what is unfortunately so often overlooked are sclerotomal structures. What are these? Ligaments, tendons, bursa, periosteum, and theses. How many times have you in your clinical practice seen patients who've been diagnosed with an itis who do not respond to local injections or local treatment? If they don't respond to the local injection, the anti-inflammatory, it's very possible that this is not a local inflammation at all. It could be, that's the caveat, a sclerotomal manifestation of segmental sensitization. And the source of that sensitization could be coming from the myofascial tissues, it could be coming from viscera, it could be coming from both, right? Those sources could have been eliminated in terms of they could have been treated, but the patient has been sensitized. And so now this can be an ongoing chronic pain problem, as we will discuss. Now, let's add on to that picture we've already been discussing. We already mentioned about the profound changes that we know occur in the limbic system. And again, the dynamic modulation that occurs between the brain and spinal cord. So just imagine if you have patients who have dysfunctional descending inhibition and or persistent sources of nociceptive bombardment. Aren't they more likely to develop mirror image pain, meaning pain in the opposite side in the absence of any local nociceptive activity? Aren't they more likely to see spread of activity up and down their cord? The answer is yes. And the evidence of that, of course, is symptoms and findings associated with expansion of the receptive field of pain, more allodynia, hyperalgesia, and what I describe, what we sometimes talk about is the metastasis of myofascial pain, that it spreads. But it's not just myofascial. Any structure, dermatome, myotome, sclerotome, and viscerotome as well, right, can develop pain there. And so we have to be, as physiatrists, so mindful of that. because of the complexity of the cases that we so often see. So let's go back to our original patient. Let's say you identify an active trigger point there. You do a trigger point injection, or you do a dry needling treatment, myofascial release if you're a physical therapist. It doesn't matter. Some treatment in which you eliminate that, okay? So if that was the cause, right, of the nociceptive bombardment, we can call that the chicken, right? So meaning that it likely was what triggered this cascade. You still have to make sure that by treating that, you've eliminated the signs of sensitization. Many times they still persist, and we'll talk about why. But if you treat the trigger point and it keeps recurring, of course, we have to look for perpetuating factors, etc. But now think to yourself, please, maybe this is the egg. Maybe this is a manifestation of something else, that the trigger point is not a primary source of dysfunction at all. It could be secondary, a manifestation. Now, some of those chickens can become eggs, and the eggs can hatch to become chickens. Okay, you could go crazy thinking about it. But I'm just trying to get us to think now, and instead of this cause and effect, think about this as this dynamic interaction that's occurring between the peripheral nervous system and the central nervous system. And again, you can simply use, and this is what we teach in our workshops, signs of allodynia to look for segmental sensitization. And as we said, hyperalgesia using, for example, a pinwheel and identify those zones that are sensitized. And one can do a paraspinous block. One can utilize acupuncture needles. One can utilize microcurrent, these handheld devices that we use all the time in the clinic to treat the sensitized segment, demonstrate to the patient. And what you see here is an almost immediate, almost like flipping a light switch, reduction either in the segmental findings and or in the pain pressure threshold using, for example, an algometer, etc. So in addition to a subjective improvement of pain, we want to see that, but we also want to see objective improvement in these physical findings. So what's the structure that we are targeting? It is very simple. It's the medial branch of the posterior primary rami, that segment that is corresponding to where the patient has their pain complaint, and that is likely the sensitized area. What's fascinating to me, and any of you who practice acupuncture, as I do, is the fact that these are overlap really elegantly with some of these well-known back shoe points. And it's those of you who are familiar with neuroanatomical acupuncture, this is the likely mechanism by which some of these treatments work. So the pinch and roll test is very easy to do. In fact, in some people, it's so easy, you don't have to even pinch the skin. The roll is right there. Okay, so now we understand, again, based upon Mensah's work, that muscle pain is mainly due to the binding of three biochemicals: bradykinin, prostaglandins, and serotonin. And as I said, in our studies, we've demonstrated that active trigger points, we measured serotonin and bradykinin. These are elevated. By the way, in the periphery, serotonin is pro-inflammatory, right? Pro-nociceptive. In the central nervous system, it's the reverse. But I just wanted to draw your attention to this common fact. The observation studies that Mensah's work has demonstrated. We also know that you can have the so-called TRP1 receptors, vanilloid receptors, so a more acidic pH, right, can sensitize and activate this receptor. There are receptors also for ATP. We could talk about that maybe in the Q&A session. But what's really fascinating to consider is this, that once you have persistent changes that could be induced by inflammation, what do we see? We see that the B2 receptor that's constitutively expressed can now be converted to the B1. Why is this so important? Because it has a lower refractory period, meaning now it can fire more easily, and it's associated with neurogenic inflammation. I draw your attention to this for this simple fact, okay? And that is this. Let's look at the before I mention that, the other thing that's really fascinating, everyone, is that the biochemical milieu here, if it's bradykinin, serotonin, for example, it's actually associated with the production of more receptors, for example, for acidity. So you can see now, you can almost create a perfect storm potentially where you develop this local tender area that is associated with these myofascial trigger points. Now, I draw your attention to all this to say this, that while in our training we've always been taught about nociceptors as being the end organ that's receiving the noxious input, this is actually the milieu through which these neurogenic peptides are being released. So this is what I want to emphasize here to all of us, is that these muscle nociceptors are an active participant, not only in perceiving stimuli, but in the regulation, as it were, but the neurogenic inflammation that's occurring, because these neuropeptides are being released from that dorsal root ganglion all the way down into the peripheral tissue. And this, as I said, has profound clinical implications, as I will show you. So what have we learned? What does it mean? And where are we going? So one of the profound things, I think that I hope you consider it profound, is that we have to understand that inflammation, as we've learned about it, yes, it can occur with tissue injury, no doubt. You tear something, you have inflammation, of course. But the key here is to understand that neurogenic inflammation can occur in the absence of tissue injury, okay? Number one. And so when it does occur, you get the release of a variety of biochemicals, as we said, that can activate the nociceptor, sending increased signals towards the dorsal horn. There's your dorsal root ganglion, right? And you have that antidromic release of neuropeptides that, as I showed you, are being released via the nociceptor. And what will that do? It's a feed-forward mechanism. Look at that, okay? So now you have a sensitized nociceptor, and you're going to get even more bombardment coming in. So what happens? Well, if it occurs in the setting of injury, as the injury remits, right, the inflammation should remit, right? And as we know, we have powerful descending inhibition, right, mechanisms, serotonergic, catecholaminergic, right? We also have segmental inhibition at the segmental level, right? But the key I'm trying to emphasize to all of you is this, that there is this profound communication that's occurring between the nociceptor and the spinal cord and brain. And it's going in both directions. This is a picture of our two boys when they were 3 and 5, and now they're 27 and 30, and I'm the small one. But we know that neurogenic inflammation can also occur in neuropathic pain, and I'm sure you're well aware of that. But guess what? It also occurs in osteoarthritis. It occurs after trauma. It's been demonstrated in CRPS. But more important than that, even as common as all these conditions are, is that neurogenic inflammation occurs also in asthma and in chronic visceral pain conditions such as endometriosis, cystitis, irritable bowel syndrome, inflammatory bowel disease, esophagitis. Why do I emphasize all this? Because it's very possible, and we have to ask ourselves, answer this question, please. Why are trigger points so commonly observed in a number of musculoskeletal and non-musculoskeletal pain syndromes in the absence of injury to the affected muscle? Because as you know, the common theory is that this type of pain is due to some type of overload of muscle, perhaps even injury to the muscle. But look at all these somatic conditions, neurologic conditions, visceral conditions. What do they have in common? Potentially C-SENS and neurogenic inflammation. That could be what is the likely mechanism, as it were, that you can develop this somatovisceral and viscerosomatic effects that we discussed. I won't have time. I'd be happy to do it in another lecture in the future to talk about our studies on chronic pelvic pain, because it really helps to fill out the picture, as it were. But what I want to share with you is this. Again, how do we explain this? Chen et al. Found resolution of the primary pathology, in this case, herpes zoster infection with medication, led to long-term resolution of trigger points, suggesting a causal relationship between an underlying infection and trigger point expression. So again, think about it. There's no injury here. There's no muscle activation or muscle overload here. What could be the potential mechanism underlying the various somatic, neurologic, visceral, infectious, cancers, etc. We have to start really expanding our model of how we're thinking about this. Now, having said all that, let's look at what we do know about the trigger points. And again, I'll try to fill out the picture a little bit more for us. So as you know, trigger points are essentially a region of several dysfunctional neuromuscular junctions. Each dysfunctional neuromuscular junction is associated with a section of muscle fiber that is maximally contracted, right? Now, have you wondered what contributes to that? I found this fascinating, everyone. What we've learned is that CGRP and a more acidic pH in the local milieu can initiate, maintain, and exacerbate the muscle contracture. So think about this. Up until this point now, we've only been discussing the sensory aspects of the myofascial pain syndrome, not the motor. But this is what is something to consider, and what we've published in one of our papers earlier is that we know that, for example, CGRP will promote the release of acetylcholine at the neuromuscular junction. It will promote the formation of acetylcholine receptors for that acetylcholine, and it inhibits acetylcholinesterase. So all these are activities that will promote, right, muscle contracture. So we have to ask ourselves now, is the neurogenic inflammation, is C-sense and neurogenic inflammation potentially not only driving some of the sensory and autonomic aspects, as I will show you, but potentially also the motor? That's an open question, something that we're investigating. Now, some of you may be familiar with the original work, and some of those of you who do EMG electrodiagnostics may be familiar with the first studies that were done by Hubbard and Burkhoff way back in '93. And what did they find? They found this abnormal continuous electrical activity at the trigger point, which they termed spontaneous electrical activity. And this occurs without normal motor end plate potentials. Why was this so important? Because it was the first electrical marker for trigger points suggesting they could be a neuromuscular disorder. So now we're putting it again in this neuro picture as it's relating to C-sense, right? But even more important was just moving 2 millimeters away from the trigger point zone, there's a change from this high amplitude SEA to electrical silence. So these small discrete spots in the muscle, as you know, can be targeted for treatment and for investigation. And Simons and Hong did many studies over the years. They found 5-fold increase in this electrical activity at the end plate, which they then termed end plate noise. And it's associated with spontaneous release of acetylcholine from the motor nerve terminal. Okay? And this is really interesting. And as I said, has pretty interesting implications. So Simon's original hypothesis, as you may know, was that there is excessive acetylcholine release, right? Which will then depolarize the sarcoplasmic reticulum. You get release of calcium, which will then cause this sarcomere contracture. But how is this being initiated? Well, you have to have the release of ATP, right? And this should be derived aerobically, and you need ATP both to activate this contracture and ATP to release it. But his hypothesis was that there is compression of the vessels, the blood vessels there, which leads to ischemia and hypoxia. And then you have this increased energy demand in the setting of a decreased energy supply, which leads to this so-called energy crisis. And this will lead to the release of sensitizing substances, including, he thought, those that can activate the autonomic nerve fibers. Because as you may know, we do have receptors for norepinephrine at this presynaptic terminal. And we did identify that active trigger points not only have elevated levels of all those inflammatory mediators, they also have elevated levels of norepinephrine as well. So there's clearly something that's happening with this inflammatory soup. And this raises lots of questions. So we have many, many years of clinical findings, and the question was, what about the underlying milieu? So our team, led by Dr. Sikdar, who, as I said, is the bioengineer, we were the first group that was able to visualize myofascial trigger points, measure their viscoelastic properties and blood flow, and demonstrate negative diastolic flow. We also demonstrated that trigger point needling that successfully reduced or resolved pain was associated with shrinkage or decrease in the size of the trigger point, which again has really interesting clinical implications. And as I said, we did microdialysis, microanalytical work, where we were able to show that active trigger points have elevated levels of all those inflammatory mediators, neuropeptides, catecholamines, neuropeptides, more acidic pH, etc. So this is, again, has pretty profound implications as it relates to sensitization and activation of this local nociceptive ending. And as we discussed, what are the changes that can occur from the periphery to the central nervous system and vice versa. Now, as you know, the common theory is that trigger points are activated by some type of overuse of the muscle, eccentric, right? Or sustained posture, or repetitive movements, right? Or a powerful concentric muscle contraction, right? That could potentially activate that trigger point. Well, irrespective of how it's activated, one of the questions I want to ask you, and as I said, we know it's associated with C-sense, is there actually a local muscle injury? Okay, that's, oops, what did I just do? Sorry about that. I must have done something. 1 second. Just I have no idea what that is. Does anybody know? Did I do that? Do you see what I'm seeing? These scribbled lines? Or is it just me? I can ignore it if you can. This is really weird. I can't even. Does anybody see this?
So it's visible to all, I guess. It's something on your screen, but
Oh no, but it's not on the screen, and I don't know how it started. I apologize. Um, uh, maybe I should just close it and reopen it. Let me do that. I don't. It's
it's
going to
done.
be very.
It's gone,
Sorry?
sir. It's gone.
It's gone. Oh yeah, thank you. Just before I clicked. Okay, thank you so much for telling me that. Okay, so why is all this important? Well, I want to make sure I don't do that again. No studies to date have demonstrated a causal link between mechanical muscle injury and formation of trigger points in myofascial pain, number one. Okay, now Larson et al. Did report, quote, surprisingly sparse histological alterations either in the muscle or trigger points, although mitochondrial changes have been described. Thus, muscle trauma or lesion does not seem to be the primary cause. Trigger points form consistently in the same location. G et al. Reported active trigger points in the infraspinatus from consistently in the mid-fiber region on the painful side. What does this mean? Well, this predictable distribution of trigger points across different muscles challenges the idea of a muscle injury etiology, which would likely present with more varied and heterogeneous trigger point distributions throughout the muscle. So let's think about all that as it relates to this theory that this is due to some type of muscle overload or injury. But also, several clinical observations have emerged to also challenge the local injury mechanism of the integrated hypothesis. As you know, if you were to overload or tear a tissue, such as muscle or ligament or tendon, you would have acute pain, right? It would be sharp and well localized. Furthermore, pressure on that muscle, if it's torn, would induce a withdrawal reflex, right? So just like if you had an inflamed joint, right? To touch that, it would be extremely tender, right? Unlike a myofascial trigger point, which patients actually like more pressure, right? So we have to explain that clinical observation that pressure on a trigger point does not induce a withdrawal reflex. Furthermore, those of you who do manual therapy also know, right, that patients often characterize it as good pain. And as you can see in this demonstration, the patient wants more pressure. But most importantly, especially for the trainees in the audience, think about the character of the pain. This is deep and achy, often diffuse and poorly localized. It gradually decreases with sustained pressure. You would not see that with injury, as everyone on this call knows. So I think that's one of the important implications to consider. So now let's go back to look at the neuroanatomy of what's happening here. Well, yes, we have this sensitized locus of nociceptors and an active locus of dysfunctional neuromuscular junctions. But guess what? Kuo found a 3 times greater density of large myelinated fibers in trigger points. So think about that. That probably explains, and more pressure receptors, greater spindle activity. So this probably explains why we can utilize treatments such as dry needling, right? And the dry needling, my colleague John Serbel has done, he's one of our team, many studies demonstrating the site-specific anti-nociceptive effects. Again, if you were to put a needle into a painful structure, into an injured structure, it would potentially it would be noxious. It would be perceived as more painful, but that's not what occurs here. So again, with dry needling, what do we see? We see this ability to use an acupuncture needle, right, and carefully localize with your non-dominant hand the trigger point, and then slowly using a pistoning action, right, elicit these local twitch responses, as you can see there. And that's been demonstrated to be essential. And one of the advantages to using acupuncture needles is that they are rounded tipped, unlike our syringes, which are beveled, right? You see this here, it's a rounded tip needle, okay? So unless you have a rationale for a particular agent that you wish to inject, you're actually doing, of course, less tissue trauma with a rounded tipped acupuncture needling. And as I said, John has done really interesting, and others have done interesting studies about that. So I just want to again allude to this concept of the muscle nociceptor, and we know that activation of muscle nociceptors is more effective in inducing neuroplastic changes compared to cutaneous nociceptors. And all of the changes that we discussed can occur, and these occur in what's been described as activity-dependent neuroplasticity. Activity-dependent neuroplasticity. So I draw your attention to this presynaptic neuron, postsynaptic neuron. Here's the inhibitory neuron. Both of these have an NMDA receptor, which is normally closed with magnesium, right? If you have a brief noxious input, you get a little bit of glutamate, a little bit of substance P, but you do not see this facilitated release, right? And importantly, you also have segmental inhibition coming from segmental inhibitory neurons, releasing GABA pre and postsynaptically. What happens if you have this persistent nociceptive bombardment? Now you get, especially from muscle, you get the co-release of glutamate and substance P in a facilitated manner. Substance P actually binds to its NK1 receptor and is internalized into the cell, as you can see here. And then glutamate and substance P together can then phosphorylate that NMDA receptor. Calcium rushes into the cell, and as you know, calcium is a very powerful second messenger, which can have these profound impacts on the postsynaptic membrane and clinically as well. Now, I wish to draw your attention to the inhibitory neuron, and look what happens here in some instances, right? With persistent bombardment, you can see the same thing, loss of the magnesium plug, and potentially dysfunction and or apoptosis of these segmental neurons. So if you have dysfunction or apoptosis segmentally, what are you more likely to see segmentally? Allodynia, hyperalgesia, less inhibition, right? So this can explain potentially what can happen over time with persistent bombardment. So remember, it's the co-release of the fast transmitter and the slow transmitter together. And that muscle, persistent bombardment from muscle, is very effective at creating these neuroplastic changes that can occur, as we said, in the dorsal horn and elsewhere as well. So one of the things I like to, when I explain to my patients, is when we explain CSENS, is think of it like when someone has a seizure, you have a loss of inhibition. So I tell the patient, you basically are having a seizure in your spinal cord, in your dorsal horn neuron. with loss of inhibition, making it easier now to now activate that particular neuron. But as I'm going to show you, it's not just the dorsal horn neuron that gets activated potentially. The ventral horn, the intermediate horn, the contralateral horn can be activated as well. And this has profound, as I said, implications postsynaptically as well. And again, just doing a simple pinch and roll test and checking for hyperalgesia in your patients with chronic pain will give you very valuable information about where they are segmentally sensitized. And we want to identify those areas where there's this loss of inhibition, whether segmentally or because of descending inhibition, dysfunctional descending inhibition, etc. Now, going back to trigger points, right? The important thing to remember with trigger points is the palpation of that taut band, right? And identifying within that taut band that hyper irritable nodule, and then reproducing their pain. And for the students, for the trainees, of course, what's important to remember is you can use either a flat or a pincer palpation to identify various trigger points. So you can see here, looking for trigger points in the masseter muscle, for example, right? And you see the common referral patterns of these trigger points, trigger points in the temporalis muscle, and the referral patterns of those trigger points. Our team, all of our studies, our clinical studies, our dry needling studies, our imaging, microanalytical studies have all been done on the upper trapezius muscle in trigger point 1. And as you can see, as you know, this can have a very varied clinical presentation depending on how sensitized they are, etc. So this is another really important concept when I learned from Dr. Mensah that, again, has pretty profound implications for us as physiatrists. And that is the following, that really no matter where one is complaining of pain, hip, knee, back, shoulder, etc., ultimately, that perception of pain depends upon the balance of sensitizing and desensitizing action, sensitizing in red, desensitizing action in green, actions in the spinal cord. So the excitatory tonus, as we discussed earlier, is being caused by nociceptive activity. The inhibitory tonus is via inhibitory neurons, right? Descending inhibition, but also mechanoreceptors. And as we said, there's increased concentration of them at the trigger point site, which is probably why trigger points do respond to local treatment as well as they do, right? So this is something to consider. But I wish to draw your attention to the following. So that once a dorsal horn neuron is sensitized, it displays three important characteristics, and the following. One is increased response to external stimuli, which of course underlies allodynia and hyperalgesia. Number two, this is really important, as you'll see, spread of excitation ipsilaterally and contralaterally in the spinal cord to segments that do not normally receive input from the nociceptive bombardment. So we'll look at that. And number three, increased background activity, meaning more red, more sensitization than green. So our job as clinicians, right, is to identify those sources of persistent bombardment, turn them off. Identify the sensitized segments, okay, turn them off. Identify if there's any supraspinal component, use, biofeedback and relaxation, cognitive retraining, and all those things we know can work also to target each of the areas that could potentially be involved. But I just want to draw your attention to the spinal cord because what I'm going to show you, I'm assuming almost everybody on this call has observed situations similar to this. So let's say you have a patient that has endometriosis, as we discussed earlier. And again, these lesions can be a source of persistent bombardment. What Mensah's work and others have demonstrated is that we not only see activation of the dorsal horn, but we see activation of the ventral horn, the intermediate horn, which has effects on sympathetic ganglia. And as we already discussed, we can see in neurogenic inflammation, but in addition to that, we get what's called a dorsal root reflex, which is primary afferent depolarization, which is going antidromically. What will that do? That will increase the neurogenic inflammation that is already occurring in that structure, causing more pain in the area of the endometrial tissues or anything that shares that segmental innervation. So imagine how confounding it is to our colleagues in gynecology when they remove and treat the lesions, right? Treat and remove them, but the pain persists. And if they don't understand these concepts of C-SENS and segmental sensitization, many patients will suffer needlessly for years and years, right? You know that. So what is driving this? C-SENS is ultimately the cause of this, and it could be coming from events in the periphery as well as segmentally and supraspinally, right? But now, what I'm trying to show you is this here, this extrasegmental spread. So what can happen, right, is now this could be the primary source of dysfunction, and they could develop trigger points, right, in their pelvic floor muscles or in their rectus abdominis. They could develop pain in their knee joint, which could be mistakenly attributed to arthritis, osteoarthritis that they have there. It could certainly exacerbate it if they do have osteoarthritis simply by these segmental connections. And the way I like to think about it is almost like skid marks on the spinal cord. So what previous injuries, visceral conditions, surgeries, etc., has the patient sustained, scars, has the patient sustained over their lifetime that has now left their spinal cord and their segments vulnerable to being sensitized. You can be completely pain-free until something comes along and clicks in, right, and sensitized. So the same stimulus that I receive nociceptively, assuming that I am sensitized, Dr. Kaur, if she's not sensitized, she may not manifest those particular clinical manifestations as I might. So that's why every patient is individual, right, in terms of their history and their spinal cord history, and that has to do with how sensitized they are, where they're sensitized, etc. So this is something just to think about, and we can talk about it more later. And I'm happy to do another lecture in the future. In my workshops, I teach over 2 days, and I have got hours and hours of material to teach. But I'm just trying to give you the overall big picture here. So again, what you see here is persistent bombardment and this concept of extrasegmental spread, right? And neurogenic inflammation, both ipsilaterally and contralaterally in the spinal cord, okay? And this can have profound implications, again, on both sides. So let's say a patient has low back pain due to an active trigger point in their quadratus lumborum, right? And now, because of these mechanisms I've just described to you, they develop pain even on their opposite side. Okay, so they can develop this mirror image pain. So in Portuguese, I've been to Portugal and taught there many times, the term is dor em espelho, dorm em espelho. And those of you who are familiar, every time I go to Portugal, I'm always asked if I'm related to their prime minister. He's no longer the prime minister, but his name is Juan Antonio Costa. And his heritage, I was born in Mumbai, his heritage is also Indian, I think from Goa on his father's side. Anyway, so you get the point. Mirror image pain. The point I'm trying to make here is this can occur, of course, in the absence of nociception and with contralateral spread of excitation being driven by C-SENS and neurogenic inflammation. So this is what we're saying here, right? Persistent bombardment coming from a trigger point, from osteoarthritis, the viscera, it doesn't matter. You're going to get these effects, right? Now, well, let me just mention again here, because you can get activation of the autonomic ganglia, right, sympathetic ganglia. Those of you who have osteopathic background know that this can cause facilitation, right? And you can potentially get ischemia, metabolic dysfunction. And Dr. Sluka and William Willis at the University of Texas in San Antonio, they're the ones who first discovered this dorsal root reflex, which occurs every single time you send activity coming into the cord. And as we said, that will simply increase the neurogenic inflammation that's already occurring. And now when we start to understand what spinal facilitation is and how activity from one side of the cord can spread to the other, you can start to appreciate some of the profound clinical implications. So let me show you that here. So let's say you have, for example, facet joint facet joint arthritis, right? Persistent input coming from that. You sensitize the dorsal horn, then you activate the motor neuron pool of L4, right? So now you can potentially get reflex spasm of the myotome, activation of the myotome, as we discussed earlier, at least at the level of L3, L4. It could spread more if they're sensitized, right? You will also get the dermatome affected, as we discussed. So now you do a pinch and roll test, right? You'll see activation of the L3, L4 segment with allodynia and with hyperalgesia. And let's not forget, as we discussed earlier, sclerotomal structures, right, such as the pes anserinus, right? It could be, if it doesn't respond to local treatment, it might be that so-called bursitis, might be a sclerotomal manifestation, spinal segmental sensitization coming from persistent bombardment, in this case, the L3, L4 facet joint, right? Now, the source of the bombardment could just as easily be a trigger point, right? It could just as easily be a visceral organ, such as the endometrial tissue, the bladder, the bowels, the stomach, right? Peptic ulcer disease, you get it. And in the workshops, we also teach how you can look for signs of trophodema, and that where you have decreased, where you have sensitization, you have decreased resistance and decreased conductance. And with these tools, we can measure qualitatively the signs of sensitization, and then we can treat them, again, using electrical stimulation, using injection, using needling. We always start, if you think of the pyramid, always start with the least invasive, right, to see if you can treat the segment, etc. So, and I think what we can do now is just to emphasize the following and summarize in this way, that yes, nociceptors can be sensitized by persistent bombardment. They in turn can sensitize the dorsal horn neuron, which can do permanent damage, which then can create an uninhibited segment. And that segment can be invaded, or I should say activated, from distant sites above and below the original segmental level of input. And I love this quote from Dr. Clifford Wolf, who I'm sure many of you know. He's done some of the most influential studies in understanding neuropathic pain, where he said, the future of pain management will require the development of diagnostic methods that permit us to identify the mechanisms of pain in an individual patient, and then treatments that target those mechanisms. So what I hope I've shown you is that there's this profound connection that we have to understand and appreciate between the soma, the viscera, the spinal cord and brain, and that the trigger points that we often identify, right, might be a pathophysiological finding, right? It may not be, and it could be a consequence instead of a cause of primary dysfunction. So we have to keep that in our differential, as it were, when we're assessing our patients. So if I can have just maybe 7 more minutes, if that's okay, because we started a little bit late. Can I take 7 more minutes?
I think so, yes. We can quickly finish.
Thank you.
Just
thank you. Thank you. I just want to put it all in the context so you can understand. And again, I'm happy to come back and lecture another time. I've got lots more material to show you, which is fascinating. But I want to show you what are the spinal mechanisms underlying expansion of the receptive field of pain. Because this has, as I said, as I'm going to draw it directly to a clinical scenario. So just bear with me as I go through another study, which is done in this case, the rat, but you will see the immediate clinical implications of it. So let me set it up for you. What you see here is a dorsal horn neuron, which this is done in the rat. This dorsal horn neuron responds only to noxious pressure within this very circumscribed area in the biceps femoris muscle. And the black color signifies that it's noxious pressure that will only activate this neuron. So if you apply in a light touch, this neuron will not be activated. If you apply noxious pressure outside this receptive field, other neurons will be activated, but not this one. So what did they do? Well, they injected bradykinin. You've heard of bradykinin as it relates to trigger points, right? They injected bradykinin into the tibialis anterior, and what did they observe? Well, 5 minutes after injecting here, this neuron, which only had a connection to this very circumscribed area here, can now be excited by stimuli here and here. And Dr. Mensah asked the question, well, how is this occurring? Well, what he discovered is that we have so-called effective connections from neurons to their receptive field. So here you see the effective connection from the neuron for the biceps femoris muscle to its receptive field, the biceps femoris. Here you see the effective connection from the neuron for the tibialis anterior to its receptive field. And we also have so-called latent or ineffective connections. How do you open those up? This is where it gets so fascinating for all of us clinicians. Well, persistent nociceptive bombardment. So because of this, right, you get the release, as we already discussed, of glutamate, of substance P. These biochemicals can diffuse, right? And when they diffuse, potentially they can activate the neighboring neuron, which otherwise would have been quiescent, would not be activated by the activity there. You see? So now you have opened up that neuron such that not only does it respond to noxious stimuli here, but also look what happens, everyone. The original receptive field in just 15 minutes, think about that, now responds to innocuous pressure. And this underlies allodynia and hyperalgesia. It only took 15 minutes to induce this. And of course, it would also underlie expansion of the receptive field of pain. And so now Mensah goes on to say that you can certainly, I'll show you that clinical example now, and then we'll stop. You can have two structures which are anatomically very far apart from each other, right? The sacroiliac joint and let's say the Achilles tendon, right? And we have to understand the profound clinical implications that these connections can potentially, once these connections open up. So what opens it? Persistent nociceptive bombardment can cause ineffective synapses to become effective ones. This goes back to that concept of activity-dependent neuroplastic changes. So this is where I want to show you the clinical implications, since I'm assuming none of you treat rats, you treat humans. So let's say you have a patient that develops pain first in their lower extremity, right? Here in the leg. Then they develop pain in their SI joint. So of course, we want to rule out a sacroiliac joint dysfunction. We want to rule out radiculopathy, etc. You open the trigger point manual and you say, lo and behold, there is a trigger point 3, that does refer pain to both these locations. Mensah makes the argument, and again, based on the neuroscience here, and this is what we're operating on as well, that you could have essentially, this is what could be occurring. So what I'm showing you here is the spinal cord neurons, okay? Here at the different segmental levels. I'm showing the area L5 and S1 as red because the trigger point in the gastroc soleus initially is the one that is spontaneously painful, right? And as a result of that, as we discussed, what will that do with persistent bombardment, right? You can potentially, and remember, there's no pain yet in the sacroiliac joint. There's no pain here yet. What can happen is this, right? These ineffective synapses, through release of these neuropeptides, right, in the spinal cord, as we just showed, right? This can now convert a previously ineffective synapse into an effective one, and now you have sensitized the neurons for S2, S3, and lo and behold, the patient suddenly develops pain in the sacroiliac joint. Remember, in the absence of nociception and with a completely normal joint. So there's nothing locally that's happening here, right? So we have to, again, keep this, I believe, in our differential diagnosis. So let's say you do a local treatment, needling, injection, what have you, you turn this trigger point off. Is your work done? No, because you have to assess the subject and see, are they sensitized? If they are, it's very likely that any pain, including pain here, this pain could recur or persist, and or this SI joint pain could certainly recur or persist, right? And we have to appreciate, and I'm sure some of you are asking the question, well, okay, Jay, if it can affect S2, S3, can it also activate L3, L4? Yes. I go back now, everyone, to the concept that I showed you with the skid marks on the highway. Think of it that way. I'm showing you what can occur under ideal conditions in a pristine spinal cord. But no one's spinal cord is pristine, especially when you get to be my age, right? But as you age, and if you're more physically active, or you've had more tissue trauma, what have you, you've sensitized segments. The original injury pain might have been resolved, right? But that patient may be sensitized, okay? And that they're, until you come along now and introduce something new, they may not develop pain until you reactivate that segment. So as a result, the patient could develop pain in their knee joint, right? They could develop pain in their hip joint, of course, yeah, ipsilaterally and contralaterally. They could develop pain in their pelvic floor, right? Again, in the absence of endometriosis and persistent pelvic pain, we have to integrate that. And I'd be happy to come back and show you some of those studies as it relates to that. So I just leave you with this. The important question to ask yourself: is the trigger point the primary pathology in the syndrome, or is it a clinical manifestation of an underlying physiological mechanism? Is the trigger point the cause of the effect? Is it the chicken or the egg? So I thank you for your attention. I'd be happy to take any questions. And thank you for spending your Saturday night. As you can see, I enjoy this, and I'm really happy to have this opportunity. Thank you.
Thank you, Dr. Jay. That was very detailed and very nice presentation highlighting the pathophysiology underlying the myofascial trigger spots. And we do have few questions. The first one will be from Dr. Sanjeev Sharma. He wants to ask that what injectate will you prefer to inject in a myofascial trigger spot? Normal saline, lignocaine, cortisone?
Okay, no, my preference first is to do dry needling. And to try electrical stimulation. Yes, we use microcurrent, and we do dry needling. My preference is to do that first, and to also, Dr. Kaur, if you can explain again, if we just focus on the trigger points, no matter what we inject, if the trigger point is a secondary manifestation, we have to treat the segmental component. That's why I don't have a cookbook for you to say, let's do this, do this, do this. Try this first, try this first. Let's think about it from a neurophysiology perspective in terms of the myofascial pain. I would utilize everything in our armamentarium non-pharmacologically first as physiatrists. That includes manual therapy, right? Electrical stimulation, ultrasound, therapeutic ultrasound, etc. before we get into thinking about doing injections of certain things. That's kind of what I would look at it, because if the trigger point is secondary and not primary, you can inject it all you want and the pain will keep recurring because that's not the source of the pain. Does that help? Does that help?
Yeah, that makes a lot of sense though. My next question is, do you ever need to inject it with all these things, like other than dry needling?
Yeah, some clinicians say yes. I would say again, I have certainly done injections in the past. I'm doing them less now because with understanding the segmental implications, I found that when you treat the segment and you also address the supraspinal components, many times these trigger points just resolve and you don't need to go towards injections of various pharmacologics. So that would be my point. My goal here is to make us think from a neurophysiological perspective of what the trigger point actually is before we bring out the big guns, quote unquote.
So there was another question. I think that was the same, like lignocaine versus bupivacaine. So you already answered that. You prefer dry needling.
Yeah. Try that first, but then I would also go towards doing a paraspinous block if you're finding that the patient is sensitized. So there you can give a local anesthetic. You can name whichever one you want to do, and there you're basically treating the medial branch of the posterior primary rami. Treat that, then reassess the trigger point with your after your and many times and again you can measure with pain pressure threshold. You can measure the difference in electrical conductance, etc. And you can see the changes also on ultrasound. it's really quite fascinating. Yeah.
Then next question, Dr. Nitesh wants to ask, what do you prefer to reduce central and peripheral sensitization? Drugs
Mhm.
or needling?
Uh, Again, I'm thinking of the pyramid. So start non-pharmacologic first, and then work our way up. Clearly, there are going to be some patients where you have to also utilize medication, because what do we do in those patients with the overlap of MPS and, let's say, fibromyalgia? Then we like to try to sort of peel the layers of the onion to try to identify the myofascial and sensitized components to the pain, treat those, little by little, and to see what effect it has. I've seen many
The next
patients
question,
who've been able
sorry.
to. I'm sorry. I've seen many patients who've been able to essentially get off the pain medications that are commonly used, centrally acting. Once you've identified and treated the segmental and supraspinal, utilizing everything in our toolbox, cognitive retraining, behavioral management, relaxation, biofeedback, etc. In addition to medications, of course. Yeah.
Okay, sir. The next, Dr. Sanjeev wants to ask, any role of RFA of sensory nerves supplying the specific muscles involved in myofascial pain syndrome?
That's a great question. I personally don't have any experience with that. Does he? Has he done that? If he
That
wants to come in, he can chat.
Dr.
Yeah,
Sanjeev can answer if he is still here.
yeah.
Dr. Sanjeev, are you here in the group? Maybe he left. So,
Maybe he left. Yeah.
yeah. So next question we have, what should be the approach of treatment if we suspect a myofascial trigger spot is an effect rather than the cause?
Okay, so if the trigger, that's a beautiful question. I'm so glad they asked it. If the trigger point is the effect, okay, then what are the potential causes? Well, anything somatic or visceral, either current, acute, chronic, or even subacute. Let's say, for example, Dr. Kaur, a patient has peptic ulcer that's being managed medically, but the ulcer is getting larger. So now they're getting more nociceptive bombardment, and then they get trigger points as a result of that. So we have to treat the sensitization. We also have to treat any of the medical causes, whether it's visceral disease, etc., that are contributing to that sensitization, as well as, of course, if they have dysfunctional descending inhibition. And apropos of that question, Dr. Kaur, let me just say the following, because one of the things that I often encounter with patients is they ask this question. They say, well, my pain is in my ankle or my foot or my shoulder or my hand. Why are you examining the segments? And I say, well, think of it like a 3-story house. And you, on the 3rd level, at the end of the floor, at the end of the floor, there's a light bulb that has gone out. What's the first thing you do? They say, well, I changed the light bulb. And I said, if the light comes on, what do you conclude? The problem was local. It was a light bulb. And I said, well, that's like a trigger point. If we treat the trigger point and the pain goes away, that's fine. But what happens if the light still doesn't come on? Where do you go? The patient says, oh, I go to the circuit box. So what we're trying to explain to the patients, and we have a diagram that shows that, the segmental connections. Now, that's obviously a simplistic way, but for the layperson, they understand now that, oh, I see, you're saying that the endometriosis I had 20 years ago, even though it was treated successfully, I could now still be sensitized. I said, yes. So we have to identify those switches in your circuit box, and we have to flip them. Now, of course, if there are things happening supraspinally, we have to explain that as well. But I think that's one way to, at least I have found that the patients really glom onto, because just like they have been they've been taught to think that their problems are all local, whether it's myofascial or joint or viscera, and we're trying to get them to think more of neurophysiology and more of a segmental. And this is a way. And then what happens, Dr. Kaur, is the patients start saying, in terms of their history, oh, this happened to me so many years ago. Could that be relevant? And I'm saying it could be, because you could now be sensitized here, and this is what we have to treat the sensitization. So if that helps.
Yes. Next, Dr. Raj wants to ask, What do you prefer most, manual release or dry needling in manual release versus
What
dry needling in myofascial trigger spot?
manual what? Manual what?
Manual release.
Oh, manual release.
Yes.
You know, I've seen some outstanding manual therapists who can treat, but some of the best ones who also we have therapists who also do dry needling. And what I've heard is that the dry needling actually facilitates the manual work because paradoxically, as you know, to get into a trigger point that may be in a deeper tissue, you have to go through more layers. But if you can very precisely start with an acupuncture needle, deactivate that trigger point, and then that facilitates the manual work. And so I don't think it's, again, I don't want to give it as a cookbook. It's really more of a just thinking again from a neurophysiological perspective. And then in your patient, you can decide would you want to start here first, you want to start there first. It really depends on the talents of your team as well, people you have working with you, if that helps. I saw the
Right.
thumbs up, so I guess I answered the question.
So Dr. Farana wants to ask that in your last slide, you have said that whether myofascial trigger spots are the cause or the effect, then how to treat pain in case of endometriosis?
Ah, okay. So this is where, and I would love to come back and show you that work. So our team, and as in the introduction was mentioned, that I was part of a team with a gynecologist and a neurologist. And what we showed was that, first of all of these patients with endometriosis had clearly had myofascial dysfunction and segmental sensitization, and they had trigger points in their pelvic floor muscles. And the when the lesions were treated, were removed, what the neurologist also did was to use Botox injection in pelvic floor muscles to deactivate those trigger points. And as you know, that has a profound effect, right? Because it not only is able to block the sensitization, but it also has an effect at the neuromuscular junction as well, in terms of substance P and etc. So it's really fascinating, and I'd be happy to give that talk another time. But just the short answer is, if the patient has endometriosis, we have to also look for, as I said at the beginning of my talk, look for the myofascial component in any pain syndrome. I'm not a myofascist. I want to emphasize not all pain is myofascial, but most pain syndromes have a myofascial component. And I think our job as physiatrists is to identify and treat that.
And in this case, if we do just segmental dry needling, will that be just enough in endometriosis?
It often, segmental dry needling can often help, but some patients also need a paraspinous block.
Okay.
Because what we see is sometimes a temporary benefit with the paraspinal, and then the pain recurs. But then if you do a paraspinous block, you get a more long lasting. Yeah. And then to go back to the previous question, is there something else that's visceral, right? That could be resensitizing the spinal cord. Let's say it's coming from the bladder, right? Or coming from the bowels. So that's why I mentioned before, does the potential, this is where we kind of have to put on our detective hats as clinicians and try to identify what other concomitant somatic or visceral conditions could the patient have that is sensitizing their spinal cord and now manifesting as myofascial pain in a particular region. What I would love to do, Dr. Kaur, is also have my colleague, Dr. Serbal. He has done some really great work using animal models, but as a chiropractor, he's also done clinical work. But so you can sort of start to appreciate the role that osteoarthritis has, because that seems to be one of the common denominators, is that osteoarthritis increases with age, as does myofascial pain syndrome. But no one has looked at the overlap between these two and what could be the potential common mechanism that connects them. And one of them could be C-sens and neurogenic inflammation, as his animal studies have demonstrated beautifully. So more work to be done there, but we'd be happy to do another
And
lecture
one last
for you.
question, sir. Can you throw a light? Dr. Farana has a case to discuss that a patient with tendoachilles tear had been advised non-surgical.
Patient with what? With what?
TATA, tendoachilles tear.
I-
Tendoachilles, Achilles
I-
tendon tear.
oh,
So,
Achilles tendon.
yes, Achilles tendon
Okay,
tear.
okay, okay, okay. Sorry.
And the patient was advised non-surgical conservative treatment. Now the patient has developed allodynia at the site of tear 3 to 4 months after the tear.
Hmm.
So, how to treat this kind of patients with dry needling, or what do you think would
Well,
be?
first of all, my first question is why was surgery? Is there something torn? Is there, I thought you only said
Yes,
tendinitis. Okay,
they just said it's just a tear. How much the tear is nothing. Only non-surgical conservative treatment was advised.
okay.
So, and it's only 3 to 4 months post-injury.
Right. So, okay, so the injury presumably has healed, but they've gone on. So that fits perfectly with this example here. So it's very possible, right, that the Achilles tendon, it's not a trigger point, but the Achilles tendon was the source of persistent bombardment, and now they're developed. If what's the name of the doctor?
Dr. Farana.
Dr. Farana. So if Dr. Farana did a segmental examination, and please give, is it a he or her? He or
Uh,
she?
I have no idea.
Whatever. Just give them my email address. I'd be happy to
It's a
communicate.
girl. She.
Yeah, I'd be happy to communicate with them and explain and chat. And I'll also be happy to send you a PDF of my slides if you want to share that with everybody.
Sure, sir.
Yeah, yeah. But to go to your question, that's exactly the type of example that we have to think about. So I'm so glad that she asked the question that way, because the original injury presumably has healed, but the patient now has allodynia, has hyperalgesia. I would ask Dr. Parana if she can identify whether they also have trigger points in the gastrocsoleus muscle. The reason I say that is because the trigger points may not actually by in and of themselves be the cause, but now they may be the manifestation of the sensitization that was initiated by the Achilles tear or the Achilles tendonitis, what have you. So this is exactly the way to think about these types of what we call neuromusculoskeletal pain problems, neuromusculoskeletal pain problems, and yeah, and like I said, I didn't have time to show you an example of a patient who had chronic plantar fasciitis, 4 years of chronic plantar fasciitis. No local treatments worked at the level of the leg, the level of the ankle, the foot, what have you. They identified L5S1 segmental. They injected it, one course, second course, completely eliminated the pain, eliminated the sensitization. So after 4 years of chronic pain, showing you again how profoundly important it is for us to identify. And the beauty of this model is, again, this is neurophysiological, and you can treat this using physical modalities. And again, I emphasize that to all the groups I teach, which are mostly physiatrists, physiotherapists, osteopaths, acupuncturists, massage therapists, etc. There's many things that we can do, and we just have to be mindful of that and go from there.
Thank you so much, sir. Sir, and there's a request to share your email ID, so some people may like to communicate with you on
Oh,
that.
yeah, sure. Let me do that. Yeah, okay. So I'll just, let me just type it here so you can see it. Do you see it?
Yes, sir, we do. I
Okay, yeah.
hope those are requesting have got it.
Okay, yeah. And Dr. Kaur, as I said, I'd be happy to send a PDF of my slides.
Sure, sir.
And I have, as I said, I have a lot of other material to present that I didn't get a chance to get to. And I'm happy to do that another time. And also happy to have my colleague, if you wish to, my colleague, Dr. Serbal, and I could give a lecture together, etc. So
Sure.
whatever, I'm open.
Thank you so much, sir. I don't think we have any more questions now.
Okay, no, but thank you everyone for spending your Saturday night.
No, we learned a lot, and we hope to keep in touch with you in future and keep on taking advice and benefit from your expertise in the area.
Oh, no, my pleasure, Dr. Kaur and Dr. Gennady. Please, thank you so much for
Yeah.
inviting me. My pleasure.
And on behalf of all of the app members like Dr. Raj, Dr. Sanjeev, Dr. Minaj, Dr. Rambir, Dr. Nitesh, Dr. S.L. Yadav, who's our president, we thank you so much for sparing your valuable time for Academy of Pain Physiatrists India.
My pleasure. My pleasure. Look forward to working with you again.
Sure. Thank you so much.
Bye, everybody. Good night.
Good night, sir.
Good night.